Welcome to this explainer on the RCOG Green-top Guideline number 68. We're going to cover exactly what MRCOG candidates need to know about managing epilepsy in pregnancy. Epilepsy is actually one of the most common neurological conditions you'll see on the maternity ward. It affects up to 1% of all pregnancies. But make no mistake, the stakes here are exceptionally high. So we're going to break down the entire clinical pathway, giving you a crystal clear, evidence-based roadmap. This isn't just about passing your exams, it's about providing the absolute best care for these mothers and their babies.
We're breaking today's clinical pathway down into 5 key stages: pre-pregnancy counseling and risks, antepartum care and monitoring, intrapartum management and delivery, postpartum safety and breastfeeding, and finally, contraception and AED interactions.
All right, kicking things off with Section 1, pre-pregnancy counseling and risks.
First up, classifying the epilepsy syndrome. This is basically step 1, and it's absolutely crucial because different seizure types present completely distinct risks. Think about it. Tonic-clonic seizures carry the highest risk of sudden, unexpected death. Plus, they're linked to variable periods of fetal hypoxia. On the other hand, juvenile myoclonic epilepsy poses physical injury risks, things like suddenly dropping objects or, tragically, dropping the baby. So getting an accurate classification by a specialist is paramount before you can even assess specific maternal and fetal risks.
Now here is a magic number you definitely need to lock in for your exams: 5 milligrams. All women with epilepsy absolutely must be advised to take 5 milligrams a day of folic acid prior to conception, and they need to stay on this high dose until at least the end of the first trimester. The guideline is super clear on why. It drastically reduces the incidence of major congenital malformations, and it might even help reduce the risk of anti-epileptic drug-related cognitive deficits in the child later on.
When you're counseling on medication, there is a stark contrast in drug safety profiles that you just have to know. Sodium valproate? That is a massive danger zone. In utero exposure to sodium valproate doesn't just increase the risk of major congenital malformations like neural tube defects, it actually significantly lowers childhood IQ and bumps up the risk of childhood autism. But conversely, the evidence points to lamotrigine and carbamazepine as having much safer profiles for long-term neurodevelopment and physical malformations, provided they're used as monotherapy at lower doses. The ultimate goal is always the lowest effective dose of the safest appropriate drug.
Moving right along to Section 2, antepartum care and monitoring.
Okay, you literally have to memorize the definition of SUDEP. It stands for Sudden Unexpected Death in Epilepsy. If you look at the MRCOG reports, poorly controlled seizures are the main contributory factor to maternal deaths, and the vast majority of those specific deaths are classified as SUDEP. This is the absolute highest stakes scenario in these pregnancies. It underscores exactly why strict monitoring, managing sleep deprivation, and making sure the patient is actually taking her medication are literally life-saving interventions.
Picture this: a patient presents with a seizure in the second half of pregnancy. Do not just anchor on her epilepsy diagnosis. You have to think broadly. You need to immediately trigger your eclampsia protocols and get magnesium sulfate on board until you have a definitive diagnosis from a full neurological assessment. Rule out eclampsia first, then look for other serious pathologies like cerebral venous sinus thrombosis or metabolic crisis. If you get this diagnosis wrong, you're exposing the mother and baby to harmful treatments and missing a potentially fatal obstetric complication.
For fetal monitoring, there's a huge exam trap you should be ready for. Because anti-epileptic drugs increase the risk of small for gestational age babies by about 3.5 times, you absolutely need serial growth scans starting from 28 weeks. But, and this is a big but, routine antepartum fetal surveillance with a CTG has zero proven role here. Don't let them trick you with that distractor on the exam.
Let's jump into Section 3, intrapartum management and delivery. So, imagine you're the registrar on call. An epileptic patient starts having a prolonged seizure in labor. This is a terrifying medical emergency. It can lead to rapid maternal and fetal hypoxia, not to mention fetal acidosis from uterine hypertonus. So, how exactly are we going to manage this acutely on the ward?
While these steps are your absolute, non-negotiable clinical directives. First, establish a left lateral tilt to keep that venous return going and secure the airway with oxygenation. Second, you have to terminate the seizure as fast as possible to prevent status epilepticus. Benzodiazepines are your go-to first-line drugs here, specifically IV lorazepam or diazepam. If she's still seizing, you step it right up to a phenytoin or fosphenytoin infusion. And finally, the second the mother is stabilized, you must commence continuous electronic fetal monitoring to make sure the fetal heart rate is recovering.
Here's another classic exam trap.
People often assume that a complex medical condition automatically requires surgical delivery. But the guideline is completely explicit. Epilepsy alone is not an indication for a planned C-section or an induction of labor. The truth is, the vast majority of women with well-controlled epilepsy are going to have a totally uncomplicated vaginal delivery, and we need to be reassuring them of this throughout their entire pregnancy.
We know pain relief in labor is a huge priority, because pain and stress can actually lower the seizure threshold. But when you're prescribing analgesia, you've got to remember a very specific pharmacological quirk. Pethidine metabolizes into a compound called norpethidine, and norpethidine is known to be epileptogenic. Because of that, pethidine should be used with extreme caution or honestly just avoided altogether. Diamorphine is always the safer bet for these women.
That brings us to Section 4, postpartum safety and breastfeeding.
You really need to be hyper-aware of this specific time frame. The 3-day peripartum period, that is the absolute danger zone for maximal seizure exacerbation. And it makes sense when you think about it. The mother is facing a perfect storm of seizure triggers. She's profoundly sleep-deprived. Her body is recovering from the intense physical stress of childbirth. And frankly, she might be missing doses of her meds because of ward chaos or post-delivery vomiting.
Because this risk is so elevated, you've got to lay down some really practical safety ground rules. You need to advise the mother to nurse the baby on the floor, use very shallow baby baths, and absolutely never bathe the baby unaccompanied. And if she ever feels a warning aura coming on, she needs to immediately lay the baby down safely. These sound like simple precautions, but they drastically reduce the risk of a catastrophic accidental injury, like drowning or dropping a newborn during a sudden myoclonic jerk. Now, a super common anxiety for these moms is whether their medication is going to pass into their breast milk and hurt the baby. You must actively reassure them. Despite the fact that anti-epileptic drugs do transfer into breast milk, these mothers should be highly encouraged to breastfeed. The current evidence is clear. The risk of adverse cognitive outcomes is not increased. In fact, breastfed infants actually often show better psychomotor development, which makes it incredibly beneficial.
Finally, let's wrap up with Section 5. Contraception and AED interactions.
This is a super high-yield topic for the MRCOG. You have to understand how enzyme-inducing drugs, like carbamazepine or phenytoin, accelerate the metabolism of oral hormonal contraceptives. They severely compromise the pill's efficacy, leading to high rates of unplanned pregnancies. So for women on enzyme inducers, long-acting reversible options like the copper IUD, the levonorgestrel intrauterine system, or the depot injection are the absolute gold standard. They are UK MEC Category 1. On the flip side, non-enzyme-inducing drugs like valproate or levetiracetam don't typically restrict your contraceptive choices.
But wait, there is a massive exception to the rule, and they love testing this: lamotrigine. Even though lamotrigine is not an enzyme inducer, the interaction actually goes the other way. If you give a patient who is on lamotrigine an estrogen-containing oral contraceptive, the estrogen induces the metabolism of the lamotrigine. This can cause her blood lamotrigine levels to plummet by up to 70%, and that is going to trigger a sudden, highly dangerous increase in seizures.
So I'm going to leave you with a quick clinical vignette to test your recall of everything we've just covered. Think about the acute management protocols for a prolonged seizure, and then recall how a drug like carbamazepine interacts with standard emergency contraceptive pills, totally shifting your recommendation towards something like a copper IUD. Review the guideline, trust the pathway, and remember this: mastering these specific risk profiles isn't just about acing a test. It's quite literally the difference between a tragic outcome and bringing a mother and baby safely home. So what do you think? Are you ready for your next shift?